Hello, everyone. This is Tina Aswani Omprakash. You may know me as Own Your Crohn's. I'm from New York City. I'm a Crohn's patient and a permanent ostomate. I'm excited to be your host for tonight's IBD 101 session. On January 25th, the Crohn's and Colitis Foundation and the American Gastroenterology Association will host IBD Insider, patient updates from the Crohn's and Colitis Congress meeting in Austin, Texas. This is our first ever live virtual patient and caregiver scientific symposium. IBD Insider will provide live updates from the 2020 Crohn's and Colitis Congress, the premier conference for IBD professionals. During IBD Insider, world-renowned researchers and clinicians will be joined by patients to discuss IBD treatments, complementary therapies, and research updates. Because IBD Insider is an intermediate level educational symposium, tonight we wanted to host this Facebook chat to provide you with some background knowledge to help prepare you for this program. I'm excited to be joined tonight by Dr. Jami Kinnucan of Michigan Medicine, and soon to be joined by Dr. Rajeev Jain of Texas Digestive Disease Consultants. We're having some tech issues on that front to get Dr. Jain on, but hopefully he'll be joining in the next few minutes. So with that, I'd like to introduce Dr. Kinnucan. Please go ahead and introduce yourself, Dr. Kinnucan, if you don't mind.
Hey everyone, happy Wednesday Facebook Live. Tina, I'm super excited to be doing this event with you tonight, and I have to give you applause for really you are the brains behind making sure that we are connecting with our patients and providing them with some of the basic understanding, especially going into our Congress coming up next week. I'm one of the IBD specialists at University of Michigan. Go Blue, got to get my plug in. But I'm very excited to start addressing some of the questions that our Facebook patients have, and I think if we want to have questions, we have tons of questions that we've come up with too. So,
thank you, Dr. Kinnucan. We're very, very excited to have you as well. So over the next 45 minutes or so, we're going to give you an overview of Crohn's disease and ulcerative colitis and current IBD treatments. We want this to be as interactive as possible, so please comment below this video. Tell us who you are, where you're from, and of course, don't forget to ask questions along the way. A few important disclaimers before we get the show on the road. The information provided during tonight's chat is meant for educational purposes only. Inflammatory bowel disease is experienced differently by every patient. The views shared during today's chat do not necessarily represent the official position of the foundation. Always, always, always consult with your physician when making changes to your IBD treatment regimen. If your question isn't by any chance answered during tonight's chat, we encourage you to please contact the IBD Help Center with your questions at info@crohnscolitisfoundation.org or 888-MY-GUT-PAIN. With all of that out of the way, let's get started. So with that, Dr. Kinnucan, and we're still waiting for Dr. Jain to join, so hopefully in the next few minutes we'll have him. I wanted to start off with a brief introduction about Crohn's disease and ulcerative colitis, if you don't mind going into what they are and how they might differ from each other.
Absolutely, Tina. This is actually a common question that we get asked as providers. Crohn's disease and ulcerative colitis really fall under the big umbrella term of inflammatory bowel disease, or IBD. Probably say that throughout the talk tonight. But that's often actually confused amongst patients as well as community providers with irritable bowel syndrome. And so we want to differentiate those because we actually treat them very differently, and patients with inflammatory bowel disease can actually also have a co-diagnosis of irritable bowel syndrome. Crohn's disease and ulcerative colitis are chronic inflammatory conditions that affect the GI tract. And really, the differences between them are manyfold, but some of the differences actually just lie in where they affect the GI tract. Crohn's disease can affect anywhere from the mouth all the way down to the anal canal. Most commonly, we see patients with Crohn's disease involving the small intestine or the terminal ileum, and then the right colon. But patients can have isolated disease in their colon called Crohn's colitis, and that can sometimes be confused with the other disease that we're talking about tonight, ulcerative colitis, which is a chronic inflammatory condition that's isolated to the colon alone. Rarely do we see patients with ulcerative colitis have small intestinal inflammation, and if they do, that's called backwash ileitis. And some patients actually fall into this third category called Indeterminate Colitis, or IBD unspecified. And that's because there's features that actually look a little bit like Crohn's disease and a little bit like ulcerative colitis. And the truth is that while we've grouped these diseases into two main categories for many, many years, it's probably a combination of hundreds of different diseases. And everyone, again, as you said, experiences their inflammatory bowel disease differently. And so we often see a lot of the differences in terms of how patients present with symptoms. So sometimes patients that have just disease in their colon will have very different symptoms than patients who have disease in their small intestine. So it's really important for patients to take home tonight. Do you know what your diagnosis is? And if you don't, you need to ask your provider. And if you do you know where your disease is located? So if you have ulcerative colitis, where in the colon? And if you have Crohn's disease, where in your GI tract? Do you have disease in the upper GI tract? And those are really important things that you need to know as a patient to help with your provider understanding your symptoms.
I appreciate that, Dr. Kinnucan. I think that was very broad understanding of both Crohn's, ulcerative colitis, and as well as indeterminate colitis. I also wanted to ask you why Crohn's disease and ulcerative colitis and this sort of umbrella is called inflammatory bowel disease, if you might elucidate that a bit.
Absolutely. So they're both inflammatory diseases. So they're driven by the patient's immune system, and it's actually an inappropriate immune response to some stimuli. And there's various stimuli, so things that are in the environment, infections, rarely people have genetic predisposition, but most of our patients actually don't have a family history of Crohn's disease or ulcerative colitis, which I think confuses some people because many people think, well, I don't know anybody in my family with this. How could I possibly have this diagnosis? So these things in our environment and our predispositions genetically can lead to an inappropriate immune response, and that in this particular disease affects the GI tract. Other diseases outside of the GI tract could be things like rheumatoid arthritis or psoriasis. Those are also inflammatory conditions, and we actually share some of our medications with those diseases as well.
Great. So we have a question in the audience, and it's about the types of medications, which is what I was going to go into anyway. So why don't we move on to medications? What are the current types of medications available to treat inflammatory bowel disease and their potential side effects? And then I might get into a little bit more detail based on what this individual is asking about.
Absolutely. So that could be an entire hour, Tina, if we want to talk about therapies, which is actually a great thing. We've had a significant increase in medical therapies to treat Crohn's disease and ulcerative colitis in the last couple of years alone, which means that we have a lot of tools in our toolbox to be able to offer patients that really target the immune system. In terms of the classes of therapies, and there's a great resource that our friends on Facebook Live can go to after this in the Crohn's and Colitis Foundation website that actually compares these therapies side by side. It talks about risks and benefits of these therapies. But the first class of therapies fall into the mesalamine therapies. These are typically indicated in patients with ulcerative colitis and not in patients with Crohn's disease. And they typically act at the end of the small bowel and the colon to treat inflammation, and they can be given orally or they can be given rectally. These are actually very safe therapies, and rarely patients can have a reaction to these therapies, just like an allergy to any other medication. The next class of therapies, and the therapies that have probably been around the longest next to the mesalamine-based therapies, would be steroid-based therapies. Now, while steroids are very effective in some patients in controlling inflammation immediately, we rarely use them after 3 months. So in patients who've required steroids longer than that, then we're probably not on the right steroid-sparing therapy, which are some of the medications that I'm going to talk to you about next. We worry about steroids because of several risks. It's the #1 risk for infection out of all the drugs that we're going to talk about and therapies that we have to offer patients. In addition, we worry about bone loss. And in younger patients, we worry about growth delay or growth development issues when we have steroids. Steroids can be given in the hospital by IV. They can be given by mouth, and patients can take them per rectum as well.
Great.
The next therapies, oh, sorry, Tina.
No, please keep going.
Okay. The next class of therapies are actually small molecule therapies, and they're given all by mouth. These are considered immune modulator-based therapies. Just like the name states, they modulate or change the immune system in some way. And these are therapies that some of our listeners might be on. Azathioprine or Imuran, 6-mercaptopurine is another one, methotrexate, and most recently we have new approval for tofacitinib. This is an oral therapy that just got approved for ulcerative colitis. These therapies, again, are only taken by mouth, and some of them require a bridge with a steroid while they take effect, and some of them actually have immediate effect. But these are what we call steroid-sparing therapies. And then the last class of therapies, the ones that actually patients are most concerned about starting because they're not given by mouth and they're given in a unique way, either by an infusion or an injection, are biologic-based therapies. These therapies, there's several classes of these therapies, so types of mechanism at which these biologic therapies work are different than these oral therapies because they're large proteins. And if you were to take these therapies by mouth, you would degrade them, break them down just like you would do a piece of chicken or a piece of steak because those are proteins as well. So the only way that they can be administered effectively is by using them as an injection or an infusion. There's several anti-TNF therapies, which were the first biologic therapies available in ulcerative colitis and Crohn's disease. Infliximab, adalimumab, certolizumab, and golimumab. And then there's several anti-integrin therapies, or integrin therapies, natalizumab and vedolizumab, that are also approved in ulcerative colitis and Crohn's disease. And the most recent biologic therapy, ustekinumab, is a targeted IL interleukin 12-23 inhibitor that's also approved in psoriasis patients. Again, these are biologic therapies that can't be taken by mouth, and so the only way that they're effective is they're given by infusion or injection.
Thank you, Dr. Kinnucan. So just to clarify a little bit, there is a question about combination therapy in young patients. Specifically, this patient is asking about young male patients, but if you could just clarify a little bit about what combination therapy is. And I think there are some concerns about combination therapy and if it's safe, if you don't mind going into that a little bit.
Absolutely. So combination therapy, when you hear that, it means the use of a biologic in combination with one of those immunomodulator therapies that I talked about. So the more common combinations that we use and the ones that have been best studied are using an anti-TNF therapy, so something from the first class of biologics that I discussed, and using it in combination with either Imuran, azathioprine, 6-mercaptopurine, or methotrexate. So that's often when your provider is talking about combination therapy, that's what they're discussing. There was a big study that was done looking at Crohn's patients on infliximab by itself, infliximab plus azathioprine, and then patients who were taking azathioprine alone. 3 separate groups of patients, and they looked at outcomes in these patients with Crohn's disease and found that those patients that were on 2 therapies, that combination group, did better than the patients who were on infliximab by itself or azathioprine by itself. What we know in further studies now 10 years later, after follow-up of the SONIC trial, which is the trial that resulted in why we use combination therapy in many patients, is that combination therapy does a couple things. Number one, the importance of a drug working, especially a biologic therapy, is making sure we have enough drug in the body to overcome the degree of inflammation. So we know that when we use combination therapy with therapy, we can improve drug levels. Hey, Dr. Jain, how are you?
Sorry for the interruption.
Telling him about therapy.
I apologize for the difficulty on getting on, but I'm on.
It's okay.
No, thank you for joining us tonight, Dr. Jain. So I'm just going to let Dr. Kinnucan finish up, but I do want you to introduce yourself, and then if we could go back into the Q&A.
Thank you.
All right. So finishing up on combination therapy. So we know that it improves biologic drug levels. And we know that patients are at risk for loss of response, which means they're doing well. And then over time, the medication stops working. And we know that that loss of response can be due to anti-drug antibodies, when our bodies form an antibody to these biologic-based therapies, which are, again, protein-based therapies. And we know this combination therapy approach reduces that risk significantly. We know if you form an antibody to one therapy, biologic therapy, you're more likely to form it to the second, the third, and so on. So we know that there's a higher risk group of patients that we should be using combination therapy in. It's still being discussed whether or not we should be using this in everybody. And I think that hopefully we'll get some insight from the Congress. So please stay tuned for the IBD Insider. And if there's a subset of patients that maybe we don't need combination therapy in, and we can really use appropriate optimization of biologic monotherapy, which means using the biologics by themselves.
Sounds great. Thank you so much for clarifying that, Dr. Kinnucan. If we could just have Dr. Jain please introduce yourself and tell us a little bit about yourself, and then we can move forward. And if you don't mind me asking you the next question, Dr. Jain.
No, again, I apologize for the delay, but again, my name is Rajeev Jain. I'm a private practice gastroenterologist in Dallas, Texas at Texas Digestive Disease Consultants. I'm involved in the AGA and in the Crohn's Colitis Foundation, so I'm very excited and eager to participate in our program today and in Austin.
Sounds great. So with that, we do have a lot of questions in the audience, but in the interest of time, we're going to move forward with our agenda, and we will try to address some of your questions as they do relate to some of the things that we are going to be discussing over the next half hour or so. So with that, Dr. Jain, I wanted to ask you, what are some treatment considerations to keep in mind for pediatric adult and older adult patients? If you could clarify, those three different stratifications.
Sure. And as an adult gastroenterologist, I'm going to start the other way and start with the older patients first, and then work my way down to pediatrics. I think in older patients, particularly those 65 and older, we really have to be aware of the risks of other medical problems that they have, other medications they're taking, and the concern that immune suppression or modulation could increase the risk for infectious complications, and in particular, vaccine-preventable illnesses such as shingles, which is from herpes zoster. And so I think those are some of the bigger things we worry about in our older patients that are 65 plus. Mm-hmm. In adult patients, similar things. Again, you want to take into account the other medications they're taking. It's in the pediatric subgroup, I think that where I don't have expertise in, and I might reach out to Dr. Kinnucan, but I think with their rapid growth that they're going through and the metabolic changes and bone growth changes, those are special considerations that the gastroenterologist should take care of, the pediatric gastroenterologist that's managing their inflammatory bowel disease.
Sounds good. Dr. Kinnucan, did you want to add anything to that?
No, I mean, I agree with exactly what he said is, we worry about steroids in all age groups, but especially in our younger and our older patients, and because of that risk for infection. And many of the risks that patients worry about and come to clinic and talk about are the risks of potentially malignancy, which there are very rare risks of malignancy associated mainly with immunomodulator therapies like azathioprine and 6-mercaptopurine, but they also worry about the risk of serious infection. Again, most of the infections that we see on these therapies are preventable by vaccination. And so again, a plug for vaccinating appropriately when starting these therapies. Patients on biologics should be vaccinated to both pneumonia and flu. And then in various populations should be vaccinated with a non-live shingles vaccine called Shingrix.
Sounds great. We do have a question that talks about a teenager who's been on and off steroids for the last 2 years, wondering when getting off of steroids, will there be a growth spurt afterwards, or when after getting off steroids do teens start to see some growth? If there's any sort of general answer you're able to give to something like that.
I would have to defer to their pediatric gastroenterologist. Typically when we see patients on the adult side, they're usually 17 and above.
Sure.
And so growth plates fuse, and so patients won't see further growth after that time point. But it does happen at some point in the teenage years. I'm just not entirely sure the exact age, so I'm not sure how old this particular younger patient is. But, you know, I think the more important thing is if on and off steroids, what that means to me as a provider is that the therapy that they're on outside of the steroids is probably not working. And so, you know, consideration should be to either optimize that therapy, because whatever dose they're on might not be working, or consider alternative options or mechanisms to treat that disease. Because when patients are on and off steroids for years, it tells me that non-steroid based therapy is just probably not enough, or it's just not the right therapy for them.
That makes perfect sense. Thank you for going into that. Now, Dr. Jain, if I could ask you, does one treatment often work for patients for the lifetime of their disease, or are there many different treatments usually required as medications stop working?
That's a great question, and it really varies patient to patient. Most of the medications we provide, let's say the non-biologic agents, they tend to work for a while, but particularly the biologic agents, as Dr. Kinnucan was talking about earlier, about antibodies and so forth, it's sort of a general rule of thumb. I tell my patients that about a third of the patients don't respond off the bat. A third will respond, but then by the end of a year, maybe a third will lose response because either they're not being dosed ideally, or their body has made antibodies to fight that appropriate medication. So I think the key thing is really we want to find the best medicine as the first medicine so we can control the disease for the longest that we can. But that being said, you know, each patient is so unique that you really try to tailor therapy to that special circumstance.
And Dr. Kinnucan, I wanted to ask how you might work with patients to determine if a treatment is or isn't working.
Tina, that's a great question. And oftentimes, I think to some of the patients I even saw in clinic today, you know, patients have symptoms, and sometimes those symptoms are due to active inflammation, so persistence of their Crohn's disease or their ulcerative colitis. But sometimes just having symptoms does not mean that your disease is actually active. It actually might be an potential cause of diarrhea or abdominal pain or gas or bloating. You know, and we need to decipher what potentially is causing those symptoms that you're having. So there's many tools that we have as gastroenterologists to do that beyond just asking you how you're doing. And we can use tools like blood tests. In particular, we like C-reactive protein. Other ways that I can assess how well disease control or how well we've controlled someone's disease is using a stool test called a fecal calprotectin. And in fact, my patients do that every 6 to 12 months. And then we can use imaging studies, preferably MRI over CT scan. And we can use endoscopy, things like upper endoscopy and colonoscopy. And if those show persistent inflammation and a patient has symptoms, well, then, you know, then we look at the therapy and say, is it the right therapy? Is it dosed enough? We can often check drug levels for many of the therapies we use, even therapies that are not biologic therapies, to assess appropriate dosing of those therapies. And many patients actually require increasing their therapy dosing, and in doing that in conjunction, obviously, with their gastroenterologist or their GI provider. So, you know, first we have to establish whether or not the disease is active. And if it is active, right, therapy A, then we really need to decide if that therapy is dosed appropriately. Maybe consider adding a combination therapy if they're on therapy A alone. And if it is dosed appropriately and they've already been on combination therapy, then consider alternative mechanisms. Again, as Dr. Jain mentioned, there is about 30% of patients that take biologic-based therapies, in particular the anti-TNF therapies, that can form anti-drug antibodies. And that could be a reason that they maybe did well initially and now over the course of a year have lost response. And so it's really important that we identify why they're not doing well in that particular therapy before we make decisions to either change therapy and also to confirm that their symptoms are due to active inflammation.
That makes perfect sense. And I actually wanted to ask you, since we're talking about therapies and whether or not they're working, can you talk, both of you, if you don't mind, talk a little bit about what remission is, and how would someone like me, a Crohn's patient, know I'm in remission? How do you test for that? I know you talked a little bit about testing already, but like, what do you look for to determine if a patient's in remission, and what kinds of remission are there? If both of you don't mind taking a stab at that.
Sure, I can start. A couple of things for me. One is I like to ask the patients, how they're feeling and what their goals are for therapy. So, am I able to get to work? Am I able to do all these other different things in your life, not just your biology? That's one important part of it. But then the thing that we face as physicians is that patients, particularly with Crohn's, may clinically feel quite well and be doing a lot of things that they want to do, and their quality of life from that perspective is great. But if I were to perform perhaps a colonoscopy and see that they actually still have significant ulceration or inflammation or irritation in the ileum or colon, then I have to sit down with that patient and make sure they understand that clinically they may feel that they're in remission, but biologically their body is not. And that still puts them at risk for complications of their disease. And so there we have to continue to try to optimize therapy without affecting the other parts of the quality of life. So I think, as Dr. Kinnucan mentioned, we still would use many of those same things of imaging, endoscopy or colonoscopy, lab, both serum and what we call stool markers of inflammation. But I think it's really important, again, in the Crohn's patients to connect what's really going on in their GI tract where we can easily access it to how they're feeling.
Sure, that makes perfect sense. Now, Dr. Kinnucan, do you want to add anything to that?
Yeah, I agree with Dr. Jain, and that's exactly the approach that we take to patients. On the flip side, we have a subset of patients who, when we do an endoscopy or we do stool testing or a CRP, that all of those things are normal. But yet that patient is struggling day to day to achieve those things that are really important to them, like make it to school or make it to work, and are struggling with ongoing symptoms. So then we have to ask, why are there persistent symptoms despite overall the biology, like Dr. Jain had said, showing that things are in remission? And so sometimes symptoms can lag behind more of that biologic remission or that endoscopic remission, which means that the scope is normal or we're using markers like CRP and fecal calprotectin. But in other times, there's lots of other contributors. There's a post-inflammatory irritable bowel syndrome that we can see in patients that can take some time after the inflammation is healed. Irritable bowel syndrome, again, is seen in anywhere from 40 to 50% of our patients that have inflammatory bowel disease at some point during their diagnosis. And so, again, it's important that we differentiate what's driving those symptoms is there's very different treatments for somebody that has bacterial overgrowth is another cause of ongoing symptoms of gas, bloating, and diarrhea. Commonly after surgery, patients have issues with diarrhea, and that can be due to bile acid malabsorption, which is, again, not treated by changing their medical therapy for their Crohn's disease or ulcerative colitis, but actually by addressing the primary mechanism as to why they're having diarrhea. And that obviously would significantly change their course versus changing therapy at that point. I mean, the list goes on. And so the first step when somebody is not feeling well is to determine whether or not there's persistent inflammation. And if there is to try to optimize their treatment. And if there's not persistent inflammation, then to really focus on the second box, which is all these potential other contributors to ongoing symptoms and understanding that still has an impact on quality of life, but we manage those very differently.
That makes perfect sense. So IBS and SIBO could be components of having IBD, and a lot of patients, as you said, can have these sort of symptoms even though they might be in remission. That's a really good point. Now, what if it's sort of the reverse situation? What if I'm feeling really well, but my testing all shows ongoing disease and inflammation? What does that mean, and what sort of impact does that have on treatment, etc.? Dr. Jain, if you don't mind answering this one.
Sure. Kind of goes back to what I was saying earlier. As you mentioned, you might be feeling great. And let's use Crohn's disease as an example again. But your labs or biomarkers or something else is off. Well, we got to make sure first that those labs or those other tests are accurate. Nothing we do is perfect. So there are always false positives and false negatives. But that being the case, if I'm still concerned that you're clinically feeling well, but biologically not, I need to prove that somehow to you and me. And so often that will require some, additional either imaging or a colonoscopy. And if that's the route we have to go to figure it out, we do that because, as I mentioned again, if you have continued inflammation and you're the kind of patient where you get a stricture or narrowing, or you get a fistula or an abscess or pus pocket, then we're doing you a disservice if we're not optimizing your therapy, even though you overall feel well. Did that address your question?
Yeah, that makes perfect sense, and thank you for going into that. I do have one question where a patient's asking if constant backflow from large intestinal bacteria into the small intestine can cause physical changes in the intestinal structure leading to something like Crohn's disease. Is that something you see, since we're talking about small intestinal bacterial overgrowth, irritable bowel syndrome, that sort of thing where a patient's still having symptoms of something like that?
I have not seen small intestinal bacterial overgrowth cause those kind of structural damages or inflammation. Certainly causes gas, bloating, malabsorption, deficiencies in nutrients. I would defer to Dr. Kinnucan if she has additional comments.
No, I mean, I think that's a good question, and that actually addresses the million-dollar question, which is what causes Crohn's disease and ulcerative colitis. Again, once we figure that out, we might have a totally different discussion in terms of how do we manage and cure. But I think that, we know that there's a change in the microbiome, and microbiome in patients is the bacteria, the viruses, and the fungi that make up the composition of their GI tract. And so we know that a disruption in that microbiome, so a change from a normal state, can lead to a diseased state, which is potentially ulcerative colitis or Crohn's disease. And so not necessarily that they're a chronic reflux of these bacteria from the colon to the small intestine, but a chronic change in how those microbiome interact in a very unique way with the immune system and prevent the immune system from turning off in the GI tract. And so it's a very complex relationship that I'm trying to simplify in less than a minute answer. But essentially, we're really focusing a lot, and I think what you'll see that's going to come out on IBD Insider is some of the research that's being done on microbiome, and is there a role for therapy in the space of microbiome in terms of helping manage disease, and we're learning more. We have some early evidence that some things have not worked, like fecal transplant has not been effective in changing microbiome in a positive way to treat disease. But then in some cases, we use in various forms of Crohn's disease or ulcerative colitis resulting in a J pouch, we use probiotics that can be helpful in managing pouchitis, which is inflammation of the J pouch. So we know that there's something about changing the microbiome, giving back healthy bacteria in that sense that may benefit that particular disease state. So it's a complex question with a difficulty to answer in a short period of time.
That sounds great. Thank you for going into all of that. Now, the million-dollar question that's been coming up a lot on this chat, which we have also listed, have slated on our list as well, is generally what might the role of diet and nutrition be in the management of inflammatory bowel disease? Now, Dr. Jain, can I ask you your opinion? And then if Dr. Kinnucan, you don't mind bringing in your own experience and opinions, I would really appreciate that.
Yeah, I think diet and nutrition are critical. We don't have a clear connection yet, I believe, on what may be the optimal diet for an individual patient. But I think in general, in managing our patients we want to make sure that we're addressing issues of malnutrition that is either from ongoing inflammation or there's a fistula and so they're not absorbing things, a whole bunch of other things like that, where I think it's really important to not only get the sort of our team approach to inflammatory bowel disease, to get really a registered dietitian and nutritionist with expertise in this to assist both the physician and the patient to optimize their therapy. With regards to, is there one specific diet that will make you better? I don't think so yet, but it's sort of trial and error because everybody's unique.
Yeah, absolutely. Just like medication, right?
Absolutely.
Dr. Kinnucan, do you mind adding to that?
I mean, and that's probably the number one question that we get as providers who are seeing patients with inflammatory bowel disease is, how can I change my diet, or what did I eat that potentially caused this particular relapse of my symptoms? We do know that diet plays a significant role in patients' symptoms. And so there's been a significant amount of research looking at the low FODMAP diet in terms of how that impacts patients with irritable bowel syndrome. And we're starting to get more information about how patients with inflammatory bowel disease can use a low FODMAP diet to manage symptoms. But we don't have any evidence that doing a low FODMAP diet would result in change in inflammation. So we have lots of research that's ongoing, including the Crohn's and Colitis Foundation has the Jain study that is looking at a Mediterranean diet and looking at a specific carbohydrate diet and the impact on Crohn's disease inflammation with alterations that are in that diet. If patients ask me if I could pick one diet that I should tell them to do, I say that the Mediterranean diet is probably the safest diet because it is low in processed meats. It is high in lean, healthy meats. It is high in fruits and vegetables, so which means it's high in fiber, and we know that it's high in healthy fats. And that's probably the most blanket statement that we can make related to diet. There are some patients that should avoid diet, or fiber, and those patients usually typically have a symptomatic stricture or a narrowing in their intestine from Crohn's disease. But the false information that's been perpetuated over many years is that all patients should avoid fiber. And we're starting to learn more and more that that's the opposite, is we should really be encouraging our patients to really ramp up the amount of dietary fiber that they have, again, as long as that they don't have a symptomatic narrowing in their intestine. So more research is being done. I think that it's a hot topic for patients. It's an exciting topic for us as providers. If we could, manage disease with modifications in the diet, that would be a wonderful thing, except it's very hard to do. And what we've learned from previous studies is that a lot of these diets are restrictive, and some of them can result in malnutrition. So really, any dietary management that's done in patients with IBD should always be done in conjunction with a registered dietitian. And certainly patients should not be trying to do this on their own because, again, we don't want to restrict to the point where people actually end up malnourished.
Yeah, and I agree. And I think that there's going to be a lot more discussion on this when we do present at IBD Insider. So thank you both for going into that. The last thing I wanted to bring up is complementary and alternative medicines. Now, this is something that a lot of patients ask about. How should patients speak with their providers about incorporating complementary therapies into their treatment regimen? And do you think that this is appropriate, or do you think that this is more of something that, is adjunctive to their treatment options? I just want to hear some color on that. Dr. Jain, if you don't mind getting started with that, and I'd love to hear from Dr. Kinnucan as well.
Sure. So for these complementary and alternative therapies, it could be something such as yoga, meditation. It could be, acupuncture, or it could be certain herbs, supplements, CBD oils, and so forth. I think the first thing is having that trusting relationship between the patient and the provider, which goes both ways. And so I like to be open thinking towards my patients, and I want to hear what they have to say. My number one concern is that whatever we're trying, that one, it does not harm the patient. And that two, it doesn't have the potential to interact with whatever medications they're taking. And as long as we've got that pretty clear, I'm willing to try other things as long as they're reasonably safe and there's some data behind it. Unfortunately, for much of what we do in this realm, there's limited data. And I think there's a lot of research going on it. The NIH is funding a lot of research in this whole, what they call CAM or CAM. But I like to try one thing at a time with my patients, but making sure that it's a safe, be it a probiotic or different type of diet interventions or any of those type of things. So I think it's reasonable to have that open discussion so you can find the right pathway.
Absolutely. That makes perfect sense. And Dr. Kinnucan, do you want to add anything to this about, some of your experiences with complementary alternative medicine, or if there's any other things that you've seen patients use, whether it might be cannabis or homeopathy, things like that, that might be questions that might be directed towards you. What might you think of that?
Yeah, so I agree with Dr. Jain is that I think the important thing is having that discussion. So at each visit, we ask patients about what medical therapies they're using, traditional medical therapies, and then we talk about complementary therapies that they're using. I prefer to use the term complementary as opposed to complementary and alternative, because alternative suggests stopping traditional, evidence-based proven therapies and substituting them with therapies that actually have limited to no evidence. The therapies that have been studied, or the practices that have been studied, things like herbal supplements or cannabis or probiotics, most of those studies have been studied in the setting of patients continuing their medical therapy and adding these additions to these medical therapies. The Crohn's and Colitis Foundation has a great white paper and a position statement about cannabis that we wrote several years ago, really reviewing the literature to date. And it's a couple years old, and so there's been some newer studies that have come out in cannabis. But it's a great overview for patients to understand what we know from the literature. What have the studies shown? The numbers have been very small. Think about the clinical trials that we need to approve medication therapies, thousands of patients. Less than 100 patients have been studied using cannabis as a treatment in Crohn's disease, and less than 100 colitis. So we just don't have a lot of the numbers that we need to make, exact statements about the effectiveness of these therapies. What we do know is that many of these therapy approaches and practices help patients feel better and improve their quality of life. That is very clearly shown by the evidence that's there. But what we don't know is therapy, in addition to the medical therapies, help treat inflammation further. And that may be because we just don't have robust enough studies to be able to give us that information. So I think that there's going to be some presentations coming out of Congress, and I know that IBD Insider is going to give us an update as well. I'm excited to hear the updates in complementary therapies, and I think the most important thing that patients can do is make sure that they talk to their provider about what they're using, whether it be a herbal supplement or whether it be cannabis or whether it be a probiotic, to ensure, number one, it's safe to use with their medical therapies, and then number two, obviously, that they're not substituting. The studies that have shown complementary therapies show that patients are more likely to stop their traditional medical therapies when they use complementary therapies, likely because the complementary therapies potentially make them feel better, and that traditional medical therapy was not helping as much as they had hoped. And so we want to caution people in not doing that without having a full discussion with their provider.
100%. Thank you both, for all your insightful comments and answers tonight. And thank you all in the audience for joining tonight's IBD 101 Facebook Live presentation. A big, huge thank you to Drs. Kinnucan and Jain for taking the time out to chat with us this evening and helping to plan next week's IBD Insider program, and for all that you both do to support patients, the foundation, and the AGA. Drs. Kinnucan and Jain, do you have anything else you would like to add to this program tonight? Any additional comments? Anything else?
Just looking at some of the comments coming through on Facebook Live, it looks like there is a huge interest to talk about diet and nutrition. I want to put a plug in for the diet tab under the Crohn's and Colitis Foundation website that has an excellent webinar that has been put together talking about diet and nutrition from some experts throughout the country. I would put another plug in to stay tuned for IBD Insider, which is going to be our presentation coming live from the Congress. And then if you are on Twitter, I know that many of you are on Facebook, or all of you actually, but if you're on Twitter, follow along with the hashtag CC or CC Congress 20, which we will have updates coming to you live from all of the research presentations about, what is up and coming related to diet and nutrition and complementary therapies. But in addition, what's new and up and coming related to some of the newer medical therapies that we should expect to come out and be approved in the coming years. So follow along with us on Twitter, and I promise you won't be disappointed.
And Dr. Jain, anything you'd like to add?
No, I think you guys have summed it up very nicely. I'd like to thank everyone for allowing me to participate, but mostly thank the patients and the caregivers who have this disease. So thanks again.
And,
see y'all in Austin.
Yes. And with that, I'd just like to add to what Dr. Kinnucan said. It's not too late to register for the IBD Insider patient updates from the Crohn's and Colitis Congress. This is our first ever virtual patient symposium. It's for you all and your caregivers, and we want to bring this to you so that you have all the insights from Crohn's and Colitis Congress. And as Dr. Kinnucan mentioned, you are most welcome to join us on Twitter. Again, that hashtag is CC Congress. That's 3 C's followed by 20. So hashtag CC Congress 20, and you can follow along with a lot of the research presentations on all of these topics and more to learn about the latest in IBD. You can also register for the program, which is going to be on January 25th. From 1:30 to 3:30 p.m. Eastern Standard Time. That registration is on www.crohnscolitisfoundation.org/IBD Insider. Lastly, if you have any questions about IBD that haven't been answered tonight, or if you are looking for resources, please contact the Foundation's IBD Help Center at info@crohnscolitisfoundation.org or 888-MY-GUT-PAIN, which is 694-8872. Again, please join us. We love to have you there. This is for you and for your family. Have a great night. Thank you.
Good night.
Good night. Bye from Michigan.
Bye from Dallas.